Hello, everyone. Whether you were here yesterday or just attending today, thank you for joining us. I'm Rick Hamilton, Chief Technology Officer for the Focused Ultrasound Foundation. Now, I'd like to introduce our Day 2 speakers. First up, we have Liz Heddleston, a principal at Woods Rogers. Liz will speak on the topic of complying with existing privacy regulations when training AI/ML models using patient data. Again, of course, AI/ML is artificial intelligence and machine learning. We'll have a brief Q&A period at the end of Liz's presentation. After Liz, we'll hear from Mike Schumpert. Mike is VP of Data Science for the company Mosaic Data Science. He'll speak on the topic of best data management practices for AI/ML, with an emphasis on reducing the risk of bias. After his talk, again, we'll likewise have time for Q&A. And with that, I'm pleased to turn it over to our first speaker. Liz, the floor is yours.
Good morning. Thank you, Rick. I'm happy to be here today. The goal today is to explore the privacy implications of using patient data to train AI models. We're going to focus on HIPAA, the primary law governing patient data in the US, but as I'll briefly cover, there are other data privacy laws that may be at play because it's a fairly complex landscape. To zoom out for a second, this slide shows an excerpt of a White House press release that came out in December. This was a couple months after President Biden released an executive order on the safe, secure, and trustworthy development of AI across all industries and sectors. The subsequent press release announced the voluntary commitment of about 25 leading healthcare providers and payers toward the responsible use of AI in healthcare. Meanwhile, the HHS has been tasked with developing frameworks, policies, and potential regulatory actions regarding the use of AI in healthcare. So I expect a lot more to come in these areas. But as you can see just from this first paragraph of the press release announcing these voluntary commitments, patient privacy is front and center when considering the responsible development and deployment of AI. There's a huge amount of data needed to train and develop these technologies, and that can come with privacy and security challenges. Let's take a look at the privacy law landscape. In the United States, there is no omnibus or all-encompassing privacy law. You have privacy laws governing different industries, such as finance, education, and of course, for the healthcare industry, we have HIPAA. Brief history, HIPAA was enacted in 1996, and it put simply requires the protection of identifiable patient health information. It was followed up by a number of different amendments and implementing regulations, including the privacy rule, which we're going to discuss today, which came out in 2000. The security rule came out in 2003. 2009, we had the HITECH Act, which amended HIPAA to add the breach notification rule and expand government enforcement authority. Following that, the HITECH regulations were enacted in 2013, providing more regulations in these areas. And then most recently, just this year in April, HIPAA was amended to provide enhanced protections around patient privacy in the realm of reproductive health care. Of course, aside from HIPAA, there are other federal laws governing health data. For example, we have 42 CFR Part 2, which applies to substance use disorder information and programs that receive federal funding for substance use disorder treatment, referral, research, or similar activities. This law is even stricter than HIPAA due to the sensitivity of this kind of substance use disorder information and the historic stigmatization of individuals with substance use disorders. In addition to these federal laws, we also have state privacy laws. Virginia and many other states have their own specific laws governing the privacy of health information that overlap with HIPAA. I kind of think of these as the mini HIPAAs. And in some cases, these laws are stricter than HIPAA or have additional requirements. We also have consumer health data laws governing health data that falls outside of HIPAA. For example, the FTC Health Breach Notification Rule and Washington State's relatively new My Health, My Data Act. These laws may cover data held by tech companies and others that collect information about consumers through an app or other means, but the data is not covered by HIPAA. So the privacy landscape is complex and is likely to change in coming years as legislators seek to address the challenges and address the unique issues posed by AI. I'm going to give a brief overview of a few key concepts of HIPAA before we delve into the implications of training AI models on PHI. As I mentioned earlier, the privacy rule, which came out in 2009, is kind of the heart of HIPAA. It requires national standards to protect the privacy and confidentiality of people's medical records and their individually identifiable health information. It establishes requirements related to the use and disclosure of protected health information, and it also gives patients privacy rights related to their own health information, such as the right to be notified about how their PHI will be used or disclosed, for example, through a notice of privacy practice, and the right to access our own health information. After the privacy rule, the security rule, those regulations came out in 2003, and they really focus on protecting electronic PHI. This rule requires regulated entities to maintain administrative, technical, and physical safeguards for protecting ePHI, to identify and protect against threats to the security and integrity of this data, and to protect against impermissible uses and disclosures of ePHI breaches. And we also, another key rule is the breach notification rule, which discusses what happens if the privacy or security of protected health information is compromised. Regulated entities, if they have a breach, have reporting obligations to impacted individuals, HHS OCR, the regulator that enforces HIPAA, and sometimes the media, depending on the size of the breach, if it impacts 500 or more individuals in a given state. So those are the basic concepts. It's also important to understand who must comply with HIPAA. HIPAA doesn't cover all health data. To be covered by HIPAA, you must be a covered entity or a business associate, which has specific definitions under HIPAA. A covered entity covers just three categories: healthcare providers, basically individuals or entities that provide healthcare in some way and submit HIPAA standard transactions electronically, such as billing and insurance payer. And the common ones, of course, are hospitals, surgery centers, medical practices, doctors, things like that. So we have healthcare provider, health plans, and then the third is a healthcare clearinghouse, which is a fairly narrow category. So to be covered under HIPAA, you have to be a covered entity or a business associate, which has a fairly broad definition. I've summarized it on this slide, but basically an individual or entity must be using protected health information to perform certain functions or activities to or on behalf of a covered entity, such as a healthcare provider or plan, not simply using PHI for their own purposes. Common business associate functions and activities include claims processing and administration, data analysis, utilization review, quality assurance, billing, consulting. HIPAA has some guidance on the applicability of HIPAA to medical device manufacturers, and this analysis can be a little complex. Oftentimes, a medical device manufacturer may not be a covered entity because they might not be submitting claims to insurance for companies for reimbursement. But in some cases, the medical device manufacturer qualifies as a healthcare provider, but is not a covered entity because they're not submitting claims to payers. They can also be a business associate if they're engaged by a covered entity, a healthcare provider, to carry out the covered entity's healthcare activities. And the medical device company needs access to PHI to perform those functions on behalf of a covered entity. So, big picture, to be subject to HIPAA, you must be a covered entity or a business associate. Even if you're not a covered entity or business associate, a medical device company or AI developer may need access to patient data and must be aware of a covered entity's HIPAA compliance obligations, as that will impact your ability to obtain and use that patient data. The other key concept is to understand what PHI, protected health information, is, the million-dollar question. To know whether HIPAA applies to you, you need to figure out if you're dealing with PHI. Again, PHI has a fairly broad definition. It's information, including demographic data, that relates to the past, present, or future physical or mental health condition of an individual, the provision of health care to an individual, or the past, present, or future payment for health care. So it's broad and encompasses a lot of different kinds of data, including data that's held outside the medical record. The data also has to be able to identify an individual, or there's a reasonable basis to believe it can identify the individual. So it doesn't necessarily need to include their name or social security number, but if there's enough other information that you could reasonably identify the person and its health information, that would constitute PHI. But again, to be covered by HIPAA, you need two things. You need to be dealing with PHI, and the PHI is being handled by a covered entity or business associate or a subcontractor of a business associate. If these requirements are not met, HIPAA may not apply, and you might avoid some hefty compliance obligations. So if you're an AI developer and you want to use patient data to train the model, you need to figure out, do you need PHI to train the model? Are you a covered entity, such as a healthcare provider or a plan? If yes, you're definitely under HIPAA. If not, you may be a business associate, which could also trigger requirements under HIPAA and liability under HIPAA. Understanding HIPAA is also important because your customers and healthcare providers who are going to use the technology are covered entities and need to comply with HIPAA. A brief review of the privacy rule, which is relevant to AI. So HIPAA is a long technical set of regulations, but I think it is helpful to understand the privacy rule and understanding how HIPAA can apply to AI, and specifically how it may apply to training AI models with PHI. The privacy rule is very protective of patient privacy. It recognizes that health information can be very sensitive and personal, so therefore it should be protected. According to HHS, a major goal of the privacy rule is to ensure that patients' health information is protected while allowing the flow of that health information necessary to provide healthcare and to protect the public health and well-being. The rule seeks to strike a balance that permits important uses of patient data while protecting the privacy who seek care and treatment. Under the privacy rule, PHI may only be used or disclosed if a patient consents to that use or disclosure through a HIPAA-compliant authorization, which is a written consent that has to meet specific requirements, or the use or disclosure is specifically permitted by HIPAA under the privacy rule. HIPAA has a bunch of exceptions that allow for the use or disclosure of PHI in different circumstances to basically allow our healthcare system to function. Those include disclosures to the patient, their right to access the information, disclosures required by law, public health activities, including FDA compliance obligations, having to disclose PHI to respond to a subpoena or court order or something like that. So there's a bunch of different exceptions. In the context of AI, two important exceptions are the treatment, payment, and healthcare operations exception, which is also known as the TPO exception. You can disclose patient data for TPO purposes without patient consent, and it's commonly used in the healthcare industry. And the other important exception is research, which can apply to training AI models with PHI. I'm going to get into some more details on these in just a bit. The second major pillar of HIPAA is the security rule, which I touched on earlier. Privacy and security, of course, go hand in hand. When you're dealing with a vast amount of patient data, it can be sensitive, and it can also be a target of bad actors looking to exploit that data for financial gain. For today, we're mostly going to focus on the privacy rule, but I think it's important to be aware of the security rule because it has big implications for AI and healthcare. It basically says you have to be proactive in protecting against security threats and implementing safeguards and protocols that will protect ePHI. The 3 buckets of safeguards you are required to implement under the security rule are administrative safeguards, which are basically policies and procedures and processes to secure your PHI, including workforce training, risk assessment, things like that. Actual physical safeguards like facility access controls and device security, and then technical safeguards, which are the different types of technologies to protect ePHI, like access controls, audit logs to record activity. The security rule directly applies to both covered entities and business associates. And there's a significant amount of enforcement, not just against covered entities, but also business associates who fail to comply with the HIPAA security rule and experience a breach that compromises patient data. So how does HIPAA apply to AI? HIPAA was not drafted with AI in mind. So for now, we're applying old law to relatively new technology. HIPAA, as I mentioned, says a covered entity or business associate may not use or disclose PHI except as permitted or required by HIPAA. A threshold legal question is whether AI's processing of PHI even qualifies as a use or disclosure as defined by HIPAA. For example, does an AI model's digestion of PHI to learn or for training purposes constitute a use or disclosure under HIPAA if no human eyes ever lay eyes on that PHI? There is some older interpretive guidance from HHS that says use means the uses of the product of computer processing, not the internal computer processing that generates the product. This could arguably mean that AI's processing of PHI without a human seeing the information is not a use under HIPAA. However, this commentary comes from 2000, more than 20 years ago. It is non-binding, and HHS has likely changed their position in more recent years, especially considering the rapid technological development we've seen. Also, AI processing using PHI to learn is much more sophisticated than the computer-generated search queries that this commentary was addressing. In addition, there is more recent guidance from HHS regarding ransomware attacks that supports a more conservative approach. This guidance states that computer processing involved in ransomware attacks, basically the action of the malware accessing and encrypting data, is a disclosure of PHI. In other words, the eyes-off encryption malware is a use or disclosure of PHI. In addition, most AI activities involve some human review of data, such as the initial review of the training data set, the initial categorization of the data, like the physician identifying whether an image includes a tumor from which the AI will learn for future identification, and the quality control of AI output. Today, HHS likely considers AI's processing and analysis of PHI to be a use and therefore covered under HIPAA. Until we have more definitive guidance from HHS, the safer approach would be to treat AI processing of PHI as a use that implicates HIPAA. Now that we've gone over the basic HIPAA framework, we're going to delve into some of the HIPAA considerations related to training AI systems on PHI. So if you're an AI developer and you need to train your model on patient data, you likely need PHI, patient data, protected health information. You've determined through your analysis that you're either a covered entity or a business associate, or you need data from a covered entity like a healthcare provider or hospital system in order to train your AI model. There's two primary approaches for training AI models with PHI under HIPAA, and each comes with advantages and disadvantages. The first is to de-identify the PHI, which is to strip it of all data that ties it to specific individuals, basically to make it anonymous. The advantages, this is a pretty good option if it is feasible. If the data is de-identified, it's no longer actually considered PHI, and HIPAA no longer applies. This gives you more flexibility and gets you out of the heavy compliance burden of HIPAA. De-identified data can then be sold to an AI developer without obtaining the consent of each patient. There is more freedom with this approach because you have more options of how to use the data. You also mitigate the regulatory risk and security risks if you're using de-identified data, which doesn't identify individuals. The disadvantages for this approach is it can be infeasible to fully de-identify the data to meet the HIPAA safe harbor. It just might not be technically possible. If you rely on an automated process to de-identify it, it might not be foolproof and PHI could slip through. If you rely on a human process, that could be time-consuming and costly. It's also not foolproof. Humans make mistakes, of course. It can also be logistically challenging to fully de-identify the data. You also might have to, even if you can do it, it's reasonable to do it, you might have to take out certain information that the AI model needs for training purposes. If the data is too stripped down, it might be less useful for training the AI model, which could decrease its accuracy. If you can get past these hurdles, however, de-identification is a good approach. It's relatively straightforward and provides a lot of flexibility. The second approach is for the AI activity to fall under a permitted HIPAA exception, such as the treatment, payment, or healthcare operations exception or the research exception. I'm going to get into some more details on that in a bit. This approach can work if de-identification is not feasible and the AI activity falls into one of these exceptions, therefore allowing you to use the PHI to train the model without patient consent. The slide shows the two primary approaches, but it's important to mention there are other options. You can also train AI models using patient data if each patient has consented to this through a HIPAA-compliant authorization. If a smaller data set is being used, this could potentially be feasible. But if you need a vast amount of data, it might be very hard to get patient consent from all patients. I'm going to dive a bit more into the de-identification of PHI. Under HIPAA, in the regs, there are two ways to de-identify PHI. The first is through an expert determination. This is where a qualified expert provides a written opinion that the data cannot be used alone or in combination with other reasonably available information to identify the individual who is the subject of the information. This opinion must be rendered using generally accepted statistical and scientific principles. The expert opinion must document the methods and analysis used to make the de-identification determination. There is no specific professional degree or certification program for designating who is an expert at rendering health information de-identified. According to HHS, experts may be found in the statistical, math, or other scientific domains. From an enforcement perspective, HHS would look at the professional experience and training of the expert, as well as their actual experience using health information de-identification methodologies. The expert determination method is a good approach is if the data is largely anonymous, but you cannot strip all 18 identifiers needed to meet the HIPAA de-identification safe harbor. Some cons to the expert determination approach: it can sometimes be difficult to find an expert who can render an opinion. They tend to be in short supply. It can be costly to engage an expert, and it can take time for them to issue that opinion. The other method for de-identifying PHI under HIPAA is to fall under the safe harbor, where you remove 18 types of identifiers to make the data anonymous under the HIPAA regs. Once all these 18 categories of identifiers are removed, the data is de-identified. As long as you have no actual knowledge, the remaining information can identify an individual. This is a pretty clean and straightforward approach, but it is kind of an all or nothing scenario. You have to remove all 18 identifiers or it's not de-identified. If you miss even one category, it's still considered PHI and you're not under the safe harbor. Again, if PHI is de-identified by either method, it's no longer PHI and it's no longer subject to HIPAA. And the AI developers have flexibility to use this data to train AI models. This slide shows the 18 categories of data that need to be removed from PHI for it to be de-identified under this safe harbor. They need to be removed for the patient who's the subject of the data, as well as their relatives, employers, or household members. This is just a summary slide. There are some nuances to some of these categories. For example, under dates, you have to remove all elements of dates except the year that are directly related to the individual. This would include things like birth dates, admission dates, discharge dates, death dates, and all ages over 89 must also be stripped out of the data. I wanted to point out the last category on the gray side, any other unique identifier. This is kind of a catch-all and is important in research. For example, if you have a partial component of an identifier, it still might be sufficient to identify a patient. For example, if you use only the last 4 digits of their social security number or just part of the medical record number, that could be enough to re-identify the patient. So you have to be careful with those sorts of coded or abbreviated identifiers. But again, once it is de-identified, it's no longer PHI under HIPAA. HHS has a lot of guidance on these methods, and it's worth checking out if you are delving into this area for training AI models. For example, one frequently asked question that HHS put out addresses whether all personal names must be removed from the data, such as physician names. And HHS clarifies that physician names don't need to be removed, only the names of the individuals associated with the data, as I mentioned, the patients, their relatives, employers. However, if there are other names in the data, the covered entity and business associate needs to consider whether they could be used to identify the individual in combination with the other data, therefore triggering the actual knowledge standard. Again, if the covered entity has actual knowledge that the remaining data can be used to identify an individual, you no longer meet this safe harbor. Another interesting question is the possibility of re-identifying the data. Sophisticated AI or other technology may be able to re-identify data even if the safe harbor is met and the data is stripped of all 18 identifiers. It could occur when the de-identified data is combined with other data and processed by an ML algorithm. In addition, output data from AI may unexpectedly contain identifiable health information. So does this ruin the de-identification safe harbor? If you know of studies showing the possibility for data re-identification, does that mean you have actual knowledge the data set can be re-identified? Thankfully, HHS has provided some guidance on this general issue, not as specific to AI, but just on this issue in general. HHS says that the mere fact the covered entity is aware of studies about re-identification methods does not mean they have actual knowledge that the particular data set can be re-identified. The government does not expect a covered entity to presume re-identification capabilities to all potential recipients of de-identified data. This provides some relief for AI developers looking to use the de-identification standard to train their models on patient data. Again, back to our slide on the two approaches for using PHI to train AI models. The first, which we just covered, is to de-identify it using expert determination or by stripping it of 18 identifiers. This means you're in the HIPAA safe harbor, the data is not PHI, and HIPAA doesn't apply. The second method, which I'm going to get into now, is for the AI activity to be covered by the treatment, payment, or healthcare operations exception under HIPAA or the research exception. This might be a viable option if de-identifying the data is not feasible. Again, under HIPAA, a regulated entity cannot use or disclose PHI unless they have patient consent to do so, or if HIPAA specifically allows that use or disclosure in one of its exceptions. One of the most common exceptions used in healthcare is the treatment exception. Treatment has a broad definition under HIPAA, which is summarized on this slide. The provision, coordination, or management of healthcare and related services by one or more healthcare providers, consultation between healthcare providers relating to a patient, or referral of a patient for healthcare from one provider to another. For example, if a healthcare provider were to use AI to assist with the best course of treatment for a patient, this might be permissible under the treatment exception. HIPAA provides great latitude for providers to make disclosures for treatment purposes. It would be burdensome and interfere with patient care if a provider had to get patient consent every time it needed to disclose PHI for treatment purposes. However, the treatment exception has some limitations. To qualify as treatment, the activity must involve a healthcare provider. The activity must also be on behalf of a single patient rather than an entire population. For example, the use of AI to review a population and identify patients who would benefit from an alternative treatment is not considered a population level activity and would not qualify as treatment, but it could potentially fall under the healthcare operation exception. In the big picture, the treatment exception definitely has applicability to AI, but is probably yet less useful for using PHI to train AI models, since it focuses on the provision of healthcare to individual patients, not patient-wide, and it requires the involvement of a healthcare provider. Its narrow focus makes it less useful for AI developers looking to train AI systems using PHI. It's more useful in personalized medicine scenarios and in the day-to-day business of patient care. So out of the treatment, payment, and healthcare operations, we've talked about treatment. The P in TPO is for payment, which is also probably less useful for training AI models using patient data. AI might be very useful for payment purposes to assist with coding and making payments, but it's probably not that useful for using PHI to train AI models. O in the TPO trifecta stands for healthcare operations, and this is also one of the most commonly used HIPAA exceptions. Healthcare operations encompasses a broad range of activities, including quality assessment and improvement activities, case management and care coordination, conducting or arranging for medical reviews or audits, business planning, development, and administration, just to name a few. Like the treatment exception, however, the healthcare operations exception has its limits. It must involve the healthcare operations of the covered entity. The business associate, if an AI developer is a business associate, cannot use this exception to perform healthcare operations solely for their own benefit. Importantly, HIPAA specifically includes the de-identification of PHI as a healthcare operation. This can be useful for an AI developer because you may need patient data from a covered entity to train your AI model. The covered entity is probably not going to want to de-identify the data for you if it isn't already de-identified. However, the healthcare operations exception allows the covered entity to disclose PHI to a vendor for the specific purposes of de-identifying that data. This data can then be used by that covered entity, the healthcare provider, for any purpose, including for their own use or to sell to an AI developer. The business associate can also that de-identifies the data can also use that data for their own purposes if that is permitted by the business associate between the two parties, the business associate agreement. HHS has issued some guidance allowing this, but you do need to be careful to have an appropriate business associate agreement in place. However, if an AI developer is using PHI, not de-identified data, to train the AI model under the healthcare operations exception, then the AI model may need to be siloed, so it is only used with a particular covered entity that provided that patient data. That's why using the de-identification data can sometimes be preferable because there's more flexibility in how that data can be used. As I mentioned, under HIPAA, the healthcare operations exception includes conducting quality assessment and improvement activities, including outcomes evaluation and developing clinical guidelines, provided that obtaining generalized knowledge is not the primary purpose of any studies resulting from such activities. Again, if the disclosure falls under these healthcare operations purposes, patient authorizations are not needed. Research, which is a separate exception under HIPAA, on the other hand, refers to the systematic investigation, including research development, testing, and evaluation, designed to develop or contribute to generalized knowledge. The line between healthcare operations and research can be blurry. If the purpose of training the AI model using PHI is to improve the quality of care, evaluate outcomes, or develop clinical guidelines, this activity could potentially fall under either exception. According to HHS, the key inquiry is to determine whether the primary purpose of the activity is to contribute to generalized knowledge. If yes, you might be under the research exception. If no, you might be under the healthcare operations exception. HHS accounts for the fact that there could be circumstances when an activity begins as a healthcare operation to improve outcomes for a healthcare provider's own patients, and then transitions into research, i.e. contributing to generalized knowledge. If this occurs, the parties need to document the transition and begin to comply with the requirements for research. The distinction between healthcare operations and research matters because it can impact how you can use the PHI. Under healthcare operations, the AI developer that receives PHI from a covered entity may only be able to use the PHI to train an AI model for the specific covered entity that gave you the PHI. So that's pretty narrow. Under the research exception, the PHI can be used for generalized knowledge. So you can use the PHI to train AI models for use with other entities beyond the one that gave you the PHI. The research exception, as I mentioned, has the advantage of being broader than the healthcare operations exception, but it comes with its own hoops to jump through. For a covered entity to disclose PHI to a third party for research purposes, you basically have three options or pathways to do that under HIPAA. The first is that each patient signs a HIPAA-compliant authorization, which must be in writing, and the patient is consenting to the use of that PHI for use of research purposes. This can place a big administrative hurdle and is not always feasible. But if it is feasible, the patient authorization is the gold standard for disclosing PHI to third parties, including during research. The second option is to have an IRB or privacy board waive the HIPAA authorization requirements. This is more likely to be granted when it's infeasible to obtain an authorization, such as you have a large number of subjects or the risk to the data is low. It's already largely anonymous. The third option is to disclose PHI that is limited to a limited data set, and then you have a data use agreement between the covered entity and the business associate, such as an AI developer. The limited data set, you remove a lot of the identifiers, such as name, address, social security number, et cetera, but you can include more information like dates of admission, discharge, service, dates of birth, dates of death. So it is a little bit more permissive than the de-identification standard. Whenever you're dealing with HIPAA for training AI models or other purposes, you must keep in mind HIPAA's minimum necessary standard. The idea is that a covered entity or business associate must make reasonable efforts to limit the amount of PHI they're going to use to the minimum amount necessary to accomplish the intended purpose of the AI activity. Of course, there is an inherent tension between HIPAA's minimum necessary standard and AI. Generally, the more data AI receives, the better the AI will function. Data scientists will often seek as much PI as possible when developing AI algorithms. Given the minimum necessary standard, it's important to consider the scope of PHI that is really necessary for AI development and deployment. Can you think about if all the categories are really necessary, and can you use anonymous codes or take out some identifiers to make it less sensitive? The more PHI involved, the greater risk of violating the minimum necessary standard from a HIPAA compliance standpoint, and it also poses more risk from a secured cybersecurity standpoint. So the main takeaway is there's two main methods for training AI systems using PHI. Both pathways can be technical and complicated and come with pros and cons. This slide is a great starting point for HIPAA analysis when you're thinking about training models on PHI, and can help you come up with a plan to obtain or use data in a manner that still complies with HIPAA. Again, de-identification is generally the easier approach under HIPAA. It's clearer, more flexible, and there are fewer gray areas. However, if that is not an option, there are other pathways under the TPO or research exception. There is no one-size-fits-all approach under HIPAA. It is very situation dependent. A quick word on the sale of PHI, which I already alluded to. A covered entity cannot sell PHI to an AI developer unless the patient has signed an authorization that meets very specific requirements. Remember, of course, if the data has been de-identified, it is no longer PHI. Therefore, HIPAA's prohibition on selling it would not apply to de-identified data. The HIPAA penalties, also known as the why do I care slide. HIPAA is actively enforced, and there's significant financial risk for failing to comply with it, including criminal and civil liability. I will not get into the details on it, but you can take a look at the possible penalties if you're interested. And I know we're about hitting time, so if there are any questions, happy to take them.
Great. Well, thank you, Liz. And for the audience, I'd ask you again to please submit your questions using the Q&A function at the bottom of your screen. And Liz, I have to say, you've given me a new appreciation for what it takes to train models on these complex patient-centered data sets, particularly under these aging laws that were created well before widespread AI/ML use. So it's a bit of a minefield, it seems like. Let me ask a question. Have there been any kind of I mean, I'm thinking about practical terms here. Have there been any kind of enforcement activities that you're aware of regarding the use of patient data in training AI models?
Yeah, that's a good question. So as of yet, there has been no publicly disclosed HIPAA enforcement activities involving the use of AI and HIPAA. The HHS does publish their significant enforcement actions for educational purposes and as a deterrent, and people like me track this very closely. It is actively being enforced, but they've been more focused recently on HIPAA breaches and cybersecurity, as you saw with like the Change Healthcare breach. But AI is definitely on their radar screen and it's fair game. And I expect we are going to start seeing some enforcement coming down the line in terms of there could be activity behind the scenes, but in terms of some activity that's announced in terms of settlements and things like that.
Okay, great. And you mentioned the HHS has released guidance, HIPAA guidance. Is that right for AI?
So
Or did I
they
hear correct?
really don't have formal guidance yet. I'm expecting that with that new AI task force in HHS, we're likely to see some down the line. But a lot of the guidance I discussed today is older guidance that is being applied to AI within the industry.
Okay.
So again, we're the technology is well ahead of the law at this point.
Okay, very good. I'm going to try to summarize a question or two here that I'm seeing in the chat. So outside of the exceptions, do you need the patient's consent to de-identify the data before being able to freely use anonymized data? So do you need the patient's consent to de-identify?
That's a good question. So you don't the healthcare provider does not need the patient's consent to de-identify it because that's considered a healthcare operations purpose. So no patient consent is needed for healthcare operations purpose. You would need an appropriate business associate agreement if you're using a vendor to de-identify that data, but that's what's helpful about the healthcare operations purpose. No patient consent there needed to de-identify it and then use it for those other purposes. Great
Okay,
question.
very good. And I think we got time for one more question here before we move to the next speaker. Is there a specific process for assessing that the data has been properly anonymized by an expert? And do you need to reassess that anonymization on a regular basis?
There's not a formal process in the regulations. I think I kind of quoted the regs in the slides. There is a substantial amount of HHS guidance on the de-identification process. And I do recommend checking that out. They do have frequently asked questions on some of these issues. And I do think that there are times when you do have to come back and revisit whether a data set is still de-identified. So I recommend checking out the guidance on that issue.
Okay, very good. Well, I think it's about the end of the time here to move on to the next speaker. So Liz, thank you very much.
You're
Greatly
welcome.
appreciate it.
Thank you.
And momentarily, we're going to move to Mike Schumpert, and he'll be talking about best data management practices with some emphasis on bias. And, on the subject of bias, I like the way that Brad framed this yesterday. He described bias as an artifact of the math. And bias in models doesn't reflect necessarily malicious intent. It's not like a DEI thing. Bias means that your systems may not work. They, quite frankly, have been trained on a data set that may not reflect your audience. And so it's a matter that is holistic and systemic if you want systems that are trained on AI ML techniques that work for your intended uses. It's something you need to be paying attention to. And so with that, I believe we have a pre-recorded talk from Mike, and then Mike will be taking our questions live. So I'd like to queue up Mike's talk at this point, please.
Well, good afternoon. I'm really happy to be doing this session today. There's some fantastic developments that are occurring in this space right now, and it's something that gets us very excited at Mosaic. Let's just do a quick introduction. Who is Mosaic Data Science? Why am I speaking to you today? We are a small, very focused and specialized analytics firm that has been working on machine learning, AI optimization, in various analytics projects for over 20 years. So through that time, we've done over 1,000 analytics projects and deployments. We've got vast experience across our customer base. And what I think the interesting thing there for us is that, while we don't focus specifically in healthcare, you'll see quite a few big names here, maybe some names you recognize in the healthcare space. It's our cross-industry experience that actually allows us to bring insights sometimes from adjacent fields. So, we also work in manufacturing, work in hospitality, and many of the same issues we're going to talk about today are also emerging in those industries, and we can sometimes bring learning across. And interestingly, on our healthcare side, we not only work with healthcare for humans, but we also, through the Mars Pet Group, we have done quite a few projects around dogs and cats. So, to set the context for our discussion, we need to understand really what bias is and how does bias end up in AI and machine learning algorithms. The first thing that you really need to understand is that bias doesn't really have to be deliberate or conscious or the act of bad faith that somebody decided to mess something up. It's almost always unintentional, and there are many ways it can be introduced. These are some of the more common ones. We'll talk a bit more about this, but you can sometimes have bias creep into an algorithm just through skewed data sets. So you're using historical data that already has discrimination or bias treatment baked into the data itself. So you're trying to really create an algorithm for the world that you want to be, but you're basing it on data from a world as is, and maybe that will not turn out the way you expect it. So an example here is a hiring algorithm that ends up discriminating against women because men always held that position in the past, and that was the training data that was used to train the algorithm. Another common source is just, again, unintentional design choices made by the developers based upon human prejudice. And this commonly shows up in terms of flawed assumptions about what data should be brought into the model itself, right? So what should we give to the model to allow it to learn? And an example would be maybe inappropriately including race in a patient selection algorithm due to a belief that, well, with this particular treatment that we're doing the selection for, there could be genetic differences and race would be important, and failing to understand that race is not actually capturing those genetic differences very well at all, and it's just reinforcing stereotypes and biases. And then finally, another one is just is similar in that you're making poor choices during the algorithm development. Maybe you're choosing the data set, and that you're choosing the data set to train the algorithm based upon availability. It's easily available to you, so you say, I'll grab that big set of data. But the target population that you intend to use the algorithm for is not the same. And so you've probably heard about some of the facial analysis issues where because of a lack of training data for minorities, and particularly minority women, then they had very, very poor results in the end run. So bias really is, from a kind of an official, theoretical perspective, really comes down to two different types of fairness that is being evaluated and that we're trying to regulate and control for. The concept of group fairness is around equal representation of the outcomes across various demographic or protected classes. And there are different ways of measuring that. That's where the data science comes in, the statisticians come in, where you use metrics aligned with distribution itself to see whether the outcomes are properly distributed. Individual fairness is similar, but it really focuses on the individual, not surprisingly. And what we're trying to do there is say, well, the algorithm would be fair if for one individual that is very similar to another individual, they have similar outcomes. And there are different ways you can measure that. And then you can look across a number of pairwise comparisons to see if various like individuals are being treated in a similar fashion. But from a regulatory stance, what you'll most often run into is regulations being based around group fairness, and to the extent that they actually state specific metrics that they want you to use to define or evaluate whether there's equal representation or not, it's going to be around group fairness. So a very common or kind of golden rule that's often used talks about disparate impact. And it looks at whether or not you have excessive negative outcomes. So in a treatment selection case, it might be those patients that are rejected and not accepted for the treatment. Do you have excessive negative outcomes for a protected group or class given their representation within the population? And this is sometimes known as the 80% rule or the 4/5 rule, because it really looks at the worst outcomes for a protected class compared to the best outcomes, which often is not a protected class at all. It's kind of the majority class. And if that ratio gets too low, if it's lower than 80%, then you may have bias and you definitely have an obligation to investigate. So in the healthcare space, there are lots of examples. Unfortunately, they're growing year by year. You might have heard, and you might be familiar with the fact that pulse oximeters don't work as well with darker skin. Well, as recently as 2022, because of COVID, a new study was conducted to dig into this in detail, and they found that the oxygen levels in Asian, Black, and Hispanic patients was being overestimated. And again, this was because of the way the test data was used when the oximetry was originally developed. But what that specifically meant for COVID patients is that they were much more likely to have serious complications because the healthcare providers thought they were in better shape than they actually were. And you might also be aware of this one. A algorithm that's being used by many different healthcare providers for high-risk care management, so making a decision whether or not someone should be referred for high-risk care, found that the people that self-identified as Black were assigned to lower risk scores than those of equally sick, in reality, white people. And so the Black people were less likely to be referred for that extra care and suffered as a result of it. And this one, again, was a fairly straightforward and maybe understandable, but in the end, a faulty assumption that you could correlate healthcare cost with health needs. So if someone had high healthcare costs, then they probably would have high health needs. If they had low, then proportionally they should have lower health needs. Well, that totally misunderstood the fact that due to the availability of healthcare, due to a number of factors, Blacks were less likely to receive health treatment, and therefore they had lower costs, but that did not reflect their true healthiness and their health needs. And it was as bad as finding that the population for the number of people that should have been referred should have been as high as 47%, whereas the algorithm limited it to only 18%. So you obviously don't want to be one of those stories. You don't want to have that reputational risk. But aside even from that, there are financial risks that are being increasingly imposed. Several lawsuits have come out just in the last 2 or 3 years. One to do with Cigna, again, reputational risk. You don't want to be Cigna and have this happen to you. But they were using an algorithm to deny payments in batches of hundreds of thousands. The California law requires human review of denial decisions, and they were able to prove through the through the research that there was no way, we were talking about hundreds of thousands at a time, there was no way that a human could possibly be involved in these denial decisions. And even worse, when they looked into the statistics, 80% of those denials that were appealed by Cigna customers were actually overturned. So in a very similar fashion, we had United Health using a model, again, that is used by, it's licensed to several other providers. They had wrongful denial of extended care claims under Medicare. 90% of those denials were reversed when appealed. And the impact of that is, very high from a monetary perspective if you are sued. But even if you're not sued, the regulations that are coming out are really coming on the federal level and then going down to the state level. And the regulators have many tools to shut down the use of the algorithm, to impose significant fines, etc. And the context, of course, of all of this is, in some ways, healthcare is somewhat slow for the adoption of AI compared to other industries and other areas. But the growth of AI in healthcare is going to be exploding over the next few years. And I'm sure you're aware of this, you've seen it, but even in cases where there are, the patients are actually saying they're not exactly sure, they're not exactly, trusting the results, the healthcare providers are definitely planning to continue to use it. So what we're here today to talk about is how to get yourself in a position to where you can use it responsibly, and do it without, exposing your firm to risk. The main thing I would say, though, is you'll hear a lot about AI audits, and we actually offer that as a service. That's certainly fine. If you've already developed an algorithm and you're concerned, we'll come in and help you decide whether or not that is, there is any bias or there's an issue. But if you take away nothing more from today's discussion than this point, it would be that I urge you to get your governance and your act together, basically your planning together, before it comes to an audit. Do this from the beginning, and then you won't have to worry about the results of the audit. So that's what we're going to try to help you do today. So just a real simple course around, or I guess a schematic of what happens with machine learning. You heard me referring to training data earlier. You can just think of a machine learning algorithm as something that it does no more than learn from past examples. And if you say, here's a bunch of data, and I want for you to learn how to associate the outcome, let's say it's a treatment selection, based upon a whole large set of treatment selection decisions that have been made in the past, then it will do that. So the first thing you're doing is you're bringing data together from different sources. Once you think you've got a set of data that you can use to train the algorithm, you split it into the training data, and you set some identical, but with other patients involved, data aside as the test data. So think of these two data sets as identical, it's just that they're for different patients. And you then train your model, and the reason you had the test data set aside is you used it then to do evaluation. You say, all right, now that I've trained my algorithm, what would it say for this test data? And then you compare it to what actually happened. So you've got kind of a ground truth to evaluate against. And once you're happy with that, then you kind of put it in production and you start making predictions. Well, AI bias can be introduced in several different ways. The training data itself could be biased. We're going to talk about that more in a minute as an example, but we've talked a couple of different times about representation. Do you have the right training data, et cetera? The model itself could be biased. Again, not intentionally, but the way the model was trained, some of the choices around the features or the columns of data to be used. And then the outcomes, despite all of that you didn't find any bias in your training data, you didn't have any bias in the model, but regardless, you still have biased outcomes, and that can be evaluated and measured. And the good news is that at each of these points, not only can it be evaluated, but it can also be remediated. You can come back and we can help you fix the model. It's best to get it before you even start so that we don't have any issues. But models can be rehabilitated, if you will, if it's discovered that they have bias. So we've talked about training data. I just want to give you a fun example for this that hopefully you can relate to. So let's say I wanted to train a simple image classifier, and I just wanted to know whether I was presenting it a cat or a dog in the picture. So I go out and I collect some data, some photos of cats and dogs. I want to make sure that I've got equal numbers of cats and dogs, because I've learned that if I don't have representative data, I won't do a good job. So I've got these photos and I present it to a model. I train it up, and I think I'm happy. I've, through all my examples, it seemed to perform well. And now I take it to some test data that's never seen before. First thing I present it with, well, frankly, it's confused. I'm a little bit confused. I'm not exactly sure what that is either. So we'll cut it some slack and say maybe that was understandable. But the next prediction it makes is clearly wrong, and that's a little bit more concerning. So we could try it once again, and we find that it makes another error. Well, some of you might have figured out what's going on here. We were trying to train a cat versus dog classifier. But I own cats, so all these pictures are for my cats. And when I needed pictures of dogs, I went down to the park and just snapped some photos, some candid photos. Well, we ended up actually training a grass versus carpet classifier instead. And this is just a fun example, but it's a little bit of a metaphor because the model actually focused on the backgrounds and not the individuals. And in many ways, if you introduce the wrong data to your models, that's what it will learn, not the characteristics of the patient, but their background as, maybe described in demographics. So how do you handle this from a data management perspective? What can you do? First off, data management itself, is something that has been done for years. It's not new to AI and ML. You might have your IT organizations already, with strategies and implementations that are similar to this. You really need curated data, though, for developing analytics that is separate from the operational systems. So you might have your clinical data in Epic or Cerner, but you need to bring it into a data warehouse where it can be standardized. It can be, stored such that any, major studies that are being done on the analytical data doesn't affect any of your operations, and vice versa. And then off of that data warehouse, then you can run all of your various analytics, whether it be as simple as a dashboard or an advanced AI model. The good news is for the healthcare industry, you already have a standard structure for the data. And HL7 FHIR describes almost every imaginable field that one could capture for a patient. So I highly urge you to use that kind of structure and that approach, because it already gives you kind of the data dictionary. That's the technical term for the data warehouse that in many other industries they have to create. They have to come up with the definitions so that when we say profit, everybody in the company knows what we mean by profit. So what specific data are we looking to avoid, or at least to proactively manage from a bias perspective? What certain fields are just plain called out. The recent HHS final rule on algorithmic discrimination by payers and providers, recent as in 3 weeks ago, very much followed the Affordable Care Act and its definition of no discrimination on the basis of race, color, national origin, sex, age, or disability. But in healthcare, you also want to avoid discrimination according to socioeconomic status, such as the rural poor, because of all the historical wrongs that have been done to that particular class. So the good news is these kind of direct protected classes are things that are already represented in HL7, and there are specific defined fields. So if you organize your data around HL7, as I recommended on the previous slide, then you can make conscious decisions. You can make sure they're omitted from models, or if, for example, the patient or the selection model that you're going through really does need to have a different outcome or treat women differently from men because of specific characteristics, then that is fine, but you're making a conscious decision of inclusion and not just an accidental. We also have to think, though, about the indirect data to manage. And you may have heard of the concept of proxies. You've probably heard the term before, of course, but proxies in machine learning are significant because you can accidentally allow bias to be part of the algorithm, even though you didn't put race in there at all. So, for example, you don't include race, but you put in the zip code of the patient. Well, ever since there's been segregation, then you've been able to predict race through zip code to a pretty high degree of accuracy. Another example would be you don't include gender, but you ask for height, weight, and possibly even pregnancy as one of the fields. Well, you've got a pretty good sense of what gender might be, and that's creeping into the algorithm, even though you might not have intended. And it's not uncommon for some people to ask for years since graduation, maybe not so much in a healthcare perspective, but you can imagine in a hiring decision where they didn't ask for their age, but it's quite clearly a proxy for age because it's real easy to figure out the difference. So attributes that could be used as proxies must also be identified and specifically managed in your data warehouse, in your data dictionary, so that, again, all of your decisions are conscious. You're not just accidentally letting things creep in. And we mentioned, before the whole business about rural residency and wealth, et cetera. You've got to make sure that the healthcare that you're providing is both safe and effective and fair across every dimension. So we talked a lot about discrimination and bias and how it creeps into AI and ML. It may not be the case, of course, that you're building this yourself. I mean, you may find that most of your uses of AI and ML come from a vendor. Well, that's one way to get a model. You can go out and buy it pre-built. You could also bring in us as a consultant, and we do that for many customers to help them build a custom model. Or you might grow a data science practice in-house and decide to build your models yourself. That's great. But it's important to know that if you're going out on the marketplace and buying a pre-built model, that does not absolve you of responsibility. The HHS rule was very clear about you having a burden that if you have reason to believe that discriminatory variables were used, or you should have known that they would be used, and the should have known even includes just, like if you just Googled discrimination in that model type, you would have found something that would have told you, so they're not saying that it was documented, but it wouldn't have taken much effort to discover that there was potential for discrimination. Then the burden is on you to manage it, to prove it, to review it, to investigate it, to stop using the algorithm if it can't be mitigated, etc. And we are able, with our custom model work, we're able to help you avoid these problems right off the bat, because we can be more, from the very beginning, we can say, all right, well, we're not going to include this and this, but we have to remain diligent, for proxies and make sure that they're not creeping in. If the one thing I hope that you've taken away from this particular discussion on data is you have to understand your data. You have to have it documented so that you know exactly how to use it and when and where it's appropriate. So how do you do that? There is the good news again around, this goes back for many years of building data warehouses in the IT space. There is an accepted practice called data governance. And I will say that even though it's an accepted practice, it doesn't mean that everybody that builds a data warehouse actually follows it. We have many of our customers that we advise and consult with to help them set up a proper data governance after they, just started out throwing everything into a database and then later found they couldn't use it. And the reason for that is you have to have a good understanding of what data you have and all its intentions, and you have to be transparent about its availability. So these different blocks here are, kind of a common steps and common practices around data governance. Data security obviously is very important with, PHI. You're already familiar with that. But the concept of data lineage and data usability, lineage just refers to where did that field actually come from? So it could be as simple as, well, it came from Epic over here from this column, but quite often your data that ends up in a data warehouse is kind of formulated in some way. It's been calculated, and you need to make sure you understand the inputs to those calculations such that you, again, can exactly trace and track any particular connection to a protected class. And then usability is extending that lineage to say, well, if I know that it's come from a protected class, then these are the warnings that I'm going to put around it. I'm going to make sure that it's not used, unless it's really intentional and needed. But this is kind of the IT side of things. Our experience has been that you really, in the world of AI, need a holistic approach to this, and you need an overall AI governance program. So our partner, Epstein Becker Green, will help you to come up with an overall AI governance program, setting up councils, doing all the things, the training that you need to have shown that you did, the compliance programs that you set up, that ensures that not only do you have the proper processes in place to avoid any issues, but if something were to happen, you can show that you did everything you could to prevent it and thus limit your responsibility and liability. So having the governance from the data perspective and your compliance programs, all those policies and procedures in a unified, holistic approach is very critical to avoiding bias. So we've hit on several different points. I just want to summarize them here at the end again. What I would consider to be the main takeaways and the best practices. You need to have your plans in place at the start. Don't rely upon audits to save you, right? Good news is you can actually do that evaluation of whether you do have bias in the algorithms at several different places, and that bias can be mitigated. So it's not bad news if you've got an algorithm and you discover a problem. It's even better news that you discovered you had a problem before your customers did, and you've got a chance to fix it. You need properly curated data to do any type of analytic, but especially an AI model that's going to take your data and learn from it. And that needs to be separate from your operational day-to-day systems, such as, Epic. Your understanding of the data needs to be according to a standard data dictionary, and HL7 FHIR is a great one to use for that. That leads to you being able to define and manage all the columns that would be, at risk in generating a prediction or decision with bias. And finally, that comes together all with a compliance program and governance program that we can help you build through our partners. So I hope this has been informative, and we are open to questions as needed. Thank you.
Great. Well, thank you very much, Mike. And again, for the audience, I'd ask you to please submit your questions using the Q&A function at the bottom of your screen. Um, so we've got something that came in, Mike, and I recognize you don't provide legal advice, and this borders on that, but I want to put it on the table anyway. Someone has asked if an organization has a publicly facing AI tool. So you develop something with an AI component that's accessible to the public. Can they simply have a well-stated disclaimer to provide them protection in case there's any bias or inaccuracies in that output? And you may tell me seek legal guidance, but do you want to weigh in on this topic?
You preempted my answer slightly. With the understanding that I'm not a lawyer, my understanding, though, is that just having a broad, it would almost have to be you can't trust this, in which case, why would anybody use it? It is acceptable, or I have seen it happen, where if you're talking about a very narrow exception, so you've trained it on as much representative data as you could find, but you know that you only had 0.01% of the data set that covered Pacific Islanders, for example, then you might want to put a disclaimer that this tool did not have adequate representation for that group and should not be used for that purpose. But that's a very narrow exception. If you just try to broadly say, don't look at us, then why would anybody use it? So that's my understanding.
Okay, very good. There's another question. If I am already using a model, let's say I've built a model, I'm very proud of it, and I'm using this to make treatment decisions. Right. And I listen to your talk, and I'm thinking, wow, there's all these risks I hadn't really considered before. How do I ensure that what I've already created isn't biased? I mean, is there a process I can go through to retroactively assess my models?
Yes, and we touched upon this a little bit in the talk, but I think what's important in that scenario is that you have an independent third party. Now, obviously, it's self-serving to suggest that you call us through Epstein, Becker, Green, and the advisor group that we're a partner with, but it's important that you have that third party do the assessment, and not only will it stand up better if challenged, you say, look, we don't take our word for it. We had an independent person do the evaluation. But they also will likely bring expertise that you won't have if any bias is found in being able to remediate or mitigate it. So, as we touched upon, the evaluation can be done at several different points. Sometimes we have access to the insides of the model, but many times it's just a black box. All we can say is, well, we're not sure what happened in the algorithm or the training data, but we can tell you that the outcomes are not, proportional, and they're not the way they should be, and that can still be adjusted. But depending upon the circumstance, different mitigation can be applied.
Okay, and that kind of brings up a maybe a related question. Somebody, and forgive me, I don't recall if it was you or yesterday with Brad, somebody had mentioned about periodic checks to see if bias had been introduced. So if I've already validated and documented some new capability with an algorithm, and I say, yes, I feel really comfortable about this, am I finished with that process, or do I have to go back periodically and reassess it?
Yes, that touches upon a concept in machine learning called model drift. And you can think of it as simple as you took data at a point in time and you trained an algorithm. And that data at that point represented the world that you wanted to participate in. Okay, so patients were reacting this way to the drug, whatever the case may be, or to the treatment. And the reality is that the actual population that you're trying to treat and predict for can change over time. So it may not be that the human physiology changes, but environmental factors start to change, socioeconomic factors change. And so it is important to have what we call continuous monitoring and periodic checks to make sure that the model itself is not drifting in its accuracy. So that's just plain making good treatment decisions independent of bias, but then also that the changes that are happening in the population aren't accidentally introducing bias in a way that it wasn't 6 months ago. Typically, those periods are, I said 6 months ago, we put actual real-time dashboards in place for some clients, and in other cases, it's adequate to come back on a 6-month basis to do a spot check.
Okay, very good. And I appreciate that. I am looking to see if there's any other questions. Somebody has posted an AI summary of this session, so whoever did that, I appreciate it. And if there are no other questions, we will wrap this up. So again, Mike, my thanks. Liz, our thanks for your earlier presentation. And I would say for the audience, we appreciate your participation. This concludes today's webinar. My thanks to all the speakers over the last 2 days. I've personally learned a lot and hope that you each have found this time to be beneficial as well. If your questions were not answered, or if you'd like more information, please visit our website at FUS Foundation, that's FUSfoundation.org, or you can email us at info@fusfoundation.org. Again, info@fusfoundation.org. Thank you very much for joining us. Good day.